So candidate one, I can hear you loud and clear. Over to you. This is your case.
Okay, so I'm presented with axial slices of the inferior brain that include both basilar and ICA. There are normal flow voids seen in the basilar artery, but bright signal in the left ICA, concerning for a absent flow void and thus thrombus.
Excellent. So, okay, I'll take over. This is a classical case which I will show you many today, where you see this is, you remember right now I have just given you limited sequences, T2 with sequences, and suppose you were in the exam and you were going through whole of the pile of images, then it would have been more difficult. So the eye see what the mind knows. So you have to develop your checklist of looking at the basilar artery, which was beautifully mentioned. But then your checklist is this cavernous portion of internal carotid artery. So the cavernous portion of internal carotid artery presents as a flow void. And here that flow void is lost. And then you can see, you can imagine that this is the petrous ridge and the carotid canal is going through it. And even here, there is high signal. So means there is loss of flow void, means complete thrombosis of the left ICA. Well done. Yes, please.
Okay, so I'm presented with axial coronal slices, all on, well, majority T2. There is...
just look at the cavernous portion of the ICA. The same.
There's crescenteric hyperdensity in the right ICA. Worried about dissection or thrombus.
Okay. So can I ask you a theoretical question? Dissection of internal carotid artery. Which part of internal carotid artery is involved? This is an exam question, by the way.
More likely to be in the neck, where there can be, you can sustain trauma and then it propagates cranially.
Till?
Pardon?
So it propagates cranially till. Do you expect it to go into the cavernous portion? The dissection, I mean to say.
Probably not.
No. Okay, and I think the next few cases dissection is coming. We'll cover it in detail. But having said that, dissection of the internal carotid artery usually distal to the bulb within the neck, and it stops short of the the carotid canal. Very, very rare for it to go into the intracranial. So just remember it like this. Now, this was similar to the last case, but I just given you as a recap of what we did previously. Now, this time you have got a T1 weighted sequence. There is actually a erythematous plaque. Even a plaque here is slightly unusual, but it can happen. And the point here is that it can be seen on a T1, it can be seen on a T2, it can be seen on a flare sequence. Same exercise like the previous case. Okay, well done. Let me show you two cases in exam format. So just bear with me. Candidate 1, can you see case 101 and 100 written?
Yes, I can see the slide.
Okay, so yeah, so this is just for teaching and this is not for you. So the point is that this is particularly for the the ST1s and 2s who are listening to this session. Now, if you see the base of the skull, this is the carotid canal and this is the carotid canal. And And you can see that the carotid artery goes into the carotid canal like this, and then it enters, this is what we call the cavernous portion. In this particular case, you can see that there is partial stenosis of the cavernous portion, and again because of a plaque. But the idea here is to look at the anatomy, and then we can see that this is the pituitary gland. So this must be the cavernous sinus, and through the sinus, the cavernous portion of internal carotid artery, it projects anteriorly. Then when it goes anteriorly, then it goes superiorly, and what we call the subarachnoid portion. So I've not shown you more than that, but just wanted to elaborate this anatomy within the carotid canal and the cavernous portion. Okay, now another case is another case is a PD weighted sequence. Now, PD weighted sequence is a very good sequence to look at the arteries. By the way, same thing you can also see on a T2 weighted sequence most of the time. But you can see here what is happening. This is the clivus. This is a flow void of the internal carotid artery before it enters the carotid canal. Here, the flow void is not visible. So when we go superiorly, now here is that carotid canal, the flow void. The flow void is absent here. And the same thing here in the cavernous portion, and on the right side, it is visible. So please remember that, these kinds of cases, they have come in the exam so often. The examiner will open a sequence and you are going up and down and your mind is just working on the parenchyma, and actually the abnormality is sitting here. Now, superiorly, as we go superior, so this was the cavernous portion, and then superior to that is the supraclinoid portion of internal carotid artery. So if we see it just on the left, then it goes into the MCA. So this is the M1 segment of MCA, and more superiorly, this is the ACOM and the anterior cerebral. So we will come back to this later on. Okay, so candidate 1, can you see this blue screen?
Yeah.
Over to you. Your next case.
Okay, so this is a DCA carotid angiogram. I can see normal calcification of the ACA and the MCA, and I don't know the tiny branches coming off of them. So I think on a broad look, I can't see any narrowing, and all main branches appear to be patent.
So what is your conclusion?
Normal.
Normal
DSA of the this single ICA, but you'd need to look at the other side.
Okay, so I will show you an EP view. Same case, by the way.
The MCA isn't going out as far laterally as I would like.
Good. So what is the conclusion?
So there is a stenosis of the MCA.
Is
we
it
need to revise the
stenosis?
parts.
Right. Okay, fine. We will come back to this and we will revisit the case. Let's revise our intracranial anatomy, vascular anatomy. We have got an anterior circulation and we have got a posterior circulation. So from the arch of aorta is the common carotid artery. It divides into internal carotid and external carotid. The internal carotid goes into the carotid canal and goes into the intracranial component, into the intracranial cavity. And from the subclavian arteries is the vertebral arteries. They go through the foramen transversarium of some of the cervical vertebrae, and ultimately they enter through the foramen magnum, they enter the cranial cavity. If you see this schematic diagram, this is critical for you because this per se becomes an exam case. And they will show you an MRA. They can also show you a CTA, which will be a MIP sequence, just showing you this bit. Let me change because it is white, it will not show you. Now, this is the arch of aorta. So the brachiocephalic and the common carotid. Here is the left common carotid. Let's trace the left common carotid, internal carotid, external carotid. Internal carotid goes, and you can imagine that it is passing through the carotid canal and then supraclinoid portion. Actually, this is the ACA, this is the ACOM. On the other hand, look at the vertebrals. They go like this, and then they join together on time. For the exam, key thing to remember is that in this view, it is a very rare view because you will only see it on a MRA or a CTA MIP sequence. You will not see it on a DSA for the simple reason that all arteries will never be visualized on a DSA. The medialmost is the vertebral artery. So please remember this. Because an examiner will put this and one of the vertebral arteries might be absent, and if you don't know it, you will not pick it up. And then is the internal carotid, and external carotid is most lateral. So just remember these three positions. Now, this is the left and right vertebral over the brainstem. They join together to form the basilar artery. Now, so this is what happens. So this is the basilar artery, and which divides into PCA and PCA. On the other hand, this is what we call the supraclinoid portion of internal carotid artery, which has been cut here. So from here, the ACA, the anterior cerebral artery, and the MCA arises. Now, this ACA joins the other sided ACA through this anterior communicating artery. We usually call it the ACOM, written as A and COM in capital. Now, posteriorly is the PCOM, or posterior communicating artery. So this is the circle of Willis. And key thing is, and this is a 2A question for ST2s, 2A question, is MCA part of circle of Willis? This is a classical question for the exam, and the answer is no. So MCA is not a part of, this is the MCA. Circle of Willis is ACA, ICA, PCOM, PCA, basilar, PCA, PCOM, ICA, ACA, and ACOM. So this is the circle of Willis. Now, if you see here, this is the normal angiogram, AP view and the lateral view. And this is the carotid angiogram. And so please remember, closer to the exam, you have to open a atlas and revise your anatomy. This is key, number one. You should know which artery is this. I have not shown you, I'm not going to spend time on teaching you anatomy on angiogram, but I am advising you that before the exam, you have to do it, because your chances of getting a case of DSA or conventional angiogram are less, but still they show you. Please remember. And if they show you, then they will ask you anatomy. Anatomy will be, what portion is this? Which artery is this? Which artery is this? Which artery is this? This is what they are going to ask you. So orient yourself which angiogram has been done, which view it is. Some of them might have an axial view or oblique view. So you have to learn that. Particularly, the posterior circulation, you will be confused. Grossly speaking, if you see this is the AP view, and you can see that this is the internal carotid artery. It passes through the carotid canal here. This thing which is, more dense because the artery is coming towards you, you are visualizing it end on, is the cavernous portion. Then is the supraclinoid portion. Now, from the supraclinoid portion, MCA goes here and the ACA goes here. Now, if you trace the MCA has got 4 portions. I'm not going to teach you in detail. This is known as M1 segment, the horizontal segment, then M2 and M3 and M4 here. And ACA has got this A1 and then the A2. So this is the AP view, and this is the lateral view. And this is the cavernous portion where I am pointing out. This is the supraclinoid. This artery is very critical for you. This is the PCOM, the posterior communicating. Now, the point is that there are some arteries which, aneurysms are very prone to occur at particular locations. And if you don't know the anatomy, you are not going to pick them up. So once again, this is the M1 segment of the MCA. One artery, which is an exam artery, are these ones. These are not one artery, but these are the branches of M1. These are known as lenticulostriate branches of M1. They go into the basal ganglia. And some of the pathologies, particularly, I'll teach you in the next session, cryptococcus infection, which is a fungal infection. It goes through it into the basal ganglia. If you don't know it, then you will be confused what is happening. Now, M1, in this region, there is a bifurcation or at times trifurcation, and aneurysms do occur at this location. So again, I'm elaborating that I don't have time to teach you details of the angiographic anatomy, but you open an atlas before the exam and try to revise it. Now, this is your case, and this is the normal. Now, once your eyes are developed, then you can see. You see, look at this. Everything is missing. Agree? Can you get one?
Yes.
So everything is missing. Now, and actually, what has happened? If you see the AP view, there is a complete block here of M1 segment. Yeah. So from there onwards, all of this is not visible. So this was complete block occlusion of the MCA. Now, coming back to the basics of MRA. Now, please remember that MRA of the brain intracranial arteries is done without contrast, and this is what we call time of flight MRA, where contrast is not needed, and it gives you good enough pictures. Carotid, on the other hand, if you want to do carotid MRA, time of flight has got many limitations. 15-20 years ago, time of flight carotid was done as a routine. Now we do with contrast because that is not very effective. But I'll come back to that point. Okay, this is your last case, candidate 1.
Okay, so I've got a whole time of flight MRA for the arch vessels up to the intracranial fossa, and there is no opacification of the left ICA from the point at which.
So
proximally. So I've got an ICA thrombus relatively proximal, so inferior in the prior to it going into the brain, so in the neck.
Right.
Just
So
distal.
okay, so your conclusion is?
I've got a critical ICA, either filling defect or stenosis.
Mm-hmm.
And I'm concerned that there would be anterior circulation, infarct or ischemia.
Okay, so if you see here, this is an MRA. These kinds of MRAs are done with contrast. And here the main point is that we cover from the arch of aorta till the circle of Willis. So point to remember is the origin of the great arteries must be included. So if you see here, this is the internal carotid artery on the right side that is absent here. It's simple as that, that the ICA is completely absent. Portion of this is the vertebral and the vertebral, but portion of it is out of this scan plane. So it is not visible, but here you can see the vertebral and the basilar. The main point is that left-sided ICA is gone. Okay, thank you. So candidate 2, are you with us? Thank you, candidate 1.
Hi.
Okay, candidate 2, TIA 4 days after RTA, 18-year-old male. Over to you.
I've been presented with selected exercises of MRI brain. I can see on the left side, there's a concentric shape hyper intense signal within the left. I'm just trying to localize the artery, which artery would be. It's going to be the ICA.
Okay.
In keeping with the dissection of the left side.
Okay, what will you do next?
I will look for fact site axial T1 sequence in particular.
Okay. It is not available. What else will you do?
CT also is helpful.
So you're talking about the CTA, correct?
CT angiogram, CT angiogram.
Right. So instead of CTA, I'm showing you a DSA.
So it's a frontal and lateral projection of the selected DSA, which demonstrate filling defect in the left. Just trying to find out. It's trying to localize the artery, so it's common. Then internal iliac, and then it goes.
Internal?
Yeah, it's internal carotid artery of the left side. Of left side carotid artery, there's a complete occlusion. Although there's a filling with distally, probably with the collaterals, but this portion of the proximal left ICA is occluded, which is in keeping the considering the MRI finding and the DSA finding, it's in keeping with the dissection, acute dissection.
Okay, let me take over. Now, dissection is very, very important for the exam. So, first of all, etiology of dissection. In the exam, they will show you cases of stroke. This is one presentation. The patient will be young. Please remember, when a young patient comes to you with a stroke, always look for dissection. And actually, if you go back to the etiology, you will be surprised that it can be very, trivial trauma. People can get what we call dissection just by sneezing and coughing. And, gym work, boxing, breakdancing, things like that. And there can be dissection. Personally, I have seen a death in a boxing. A 21-year-old, he just died in the ring because of dissection. You remember the cricketer, what was his name? Philip Hughes, isn't it?
Yeah.
I think 2014, Australia, there was a first-class match going on, and there was a vertebral artery dissection with intracranial hemorrhage. That's a unique thing. So, dissections are very important for the exam. In the exam, either they will show you as an incidental finding, which you picked up very well, or they will show you a stroke case and the patient will be young. If the patient is young, you must rule it out. Now, as far as, so vertebral dissection I will show you, but ICA dissection is the most common dissection. About 70% of the dissections are ICA dissections. ICA dissections happen distal to the bulb and it extends, you see this is the carotid canal and extends till here. It is very, very rare, but remember it doesn't go inside. There might be case reports, but it doesn't go inside the intracranial cavity. Now, if you see this diagram, it tells you what happens. Now go back to the normal anatomy. We have got intima, media, and adventitia. So there is a defect or a tear and then blood goes here. So there will be a false lumen and a true lumen. Now here it tells you something, what is happening. That within the false lumen, the blood is so much that it just completely compresses the true lumen. And what does it tell you? That dissection can give you a finding where there will be complete occlusion of the artery. Unlike the aorta, abdominal aorta or the thoracic aorta, which is a big vessel diameter wise, these are small vessels. So radiology at times changes. You don't expect to see an intimal flap. At times it is visible, but usually not. On the other hand, in vertebral artery, it is very difficult. You won't see. And vertebral artery dissection, usually there will be complete thrombus. So with that, imaging wise, and this is a 2A question also, one of the best sequences to pick up dissection is a T1 fat saturated. You did well where you asked for a T1 fat saturated sequence. This is a T1 non-fat saturated sequence. So what is happening here? This filling defect is the true lumen, and this thing which is high signal is the clot, which is the false lumen. And it gives a crescent sign. We call it a crescent sign. Some people also call it a fried egg sign, the yolk and white. So it all depends on the age of the dissection. If you remember that the subacute hematoma, it occurs after about 4 days, which is high in signal intensity on T1. It might not be high in signal intensity if it is very early. Please remember that dissections, clinically speaking, can be evident spontaneous, as soon as they happen, but at times with delay. And delayed might be up to maybe 3-4 weeks even. So, so this is a case of dissection. Now, as far as a DSA is concerned, DSA can be looked on this window, which is an inverted window where everything is looking black, the contrast is looking black. You can invert it. It's your personal choice and everything will be white. Of course, the bones are subtracted. Now, if you see here, the main finding of dissection is that there will be tapered narrowing. Look here, go back to this diagram. You see, it goes all the way here. Tapered narrowing means that initially more lumen is visible and then less true lumen is visible. Tapered narrowing. With that, this is a finding. Considering the history, this is in keeping with a pseudo aneurysm, which can happen with dissections. So this is a dissection of the ICA. Okay, what is this?
Again, I will present with this selected T1 fat set as well on the right side, which is demonstrating crescentic shaped on the left side. There's a crescentic shaped filling defect or hypointensity or egg on yolk sign in keeping with the left-sided ICA dissection.
So this type of finding you have to develop, and you know this is a T1 fat saturated sequence where you can see this crescent, and this is an MRA which shows the same thing. Two other examples where crescent sign, you know, this is a T2 weighted sequence, and even on a T2 it can be visible. And you remember, if you you know, the hematomas I'm not going to cover today because we covered it in the first session. But just a recap that we are just talking about the signals here. And subacute hematoma is the only type of hematoma which is right on T1 weighted sequence, and it can be high in T2 weighted sequence when it is late subacute. Okay, over to you.
These are selected coronal, so it's flare on the extreme left, and then DWIs and ADC sequences, which is demonstrating high flare supratentorally in the temporal lobe on the coronal, which is showing differential restriction. Appearances are quite suggestive of a regional territory pathology in the temporal lobe. Just wondering whether there is there's no other area involved in this slice. So I'm just wondering whether there's a temporal lobe stroke. Now, which I'm just thinking about the vascular territory. Which vascular territory will it be supplying? Whether it's posterior circulation stroke, PCA is involved on the left side. I will do, if the patient is on the table, I will do MRA, time of flight, for further interrogation.
Okay. Now, this is a diffusion weighted sequence. This is the occipital lobe. This is not the temporal lobe. This shows restricted diffusion, which is, you know, bright on DWI, low on ADC map. So there is an infarct of the occipital lobe and some gyriform high signal on the flare sequence. 28 years old, and so time of flight MRA, you know, intracranial cavity, it is good for you can do it, but it's not all that good. So even if you want to do time of flight, you do sequences to rule out dissection. We call it a dissection protocol. In a dissection protocol, what we do is we do axials through the neck. These are T1, fat saturated, T2, fat saturated, and with that you can include a time of flight. But without these fat saturated T1 and T2 axials, only time of flight will not be very useful for you. So what is happening? Over to you.
So I think the patient was young and the patient had stroke, and now looking at these MRAs, I can see there's a filling defect in the right ICA. Patient must have had trauma leading to the acute stroke in the occipital posterior circulation.
Is this the ICA?
No, sorry, vertebral. Sorry, right vertebral. So it becomes.
You mean to say this right vertebral is abnormal, correct?
Yeah.
This is what you meant.
Yeah.
Okay, I will take over. Actually, the abnormality is on the left. The right is absolutely normal. This is the filling defect. If you can see on this T1 weighted sequence, some high signal here, and it goes into the foramen, and it is completely obliterated. So completely occlused, there is complete occlusion. Means that this was a dissection, but with complete occlusion. Now, going back, so why is this infarct on the contralateral side. Simple as that. Dissections can throw emboli, and this is posterior circulation. So the left vertebral was involved, but it went into the basilar, and ultimately the embolus goes on to the right side. So that is the explanation. So we also did a CTA for this patient. I am not showing you, I'm just showing you one representative area here, where you can see that this is the foramen transversarium, and you can see normal flow here. You can see no flow here. Please remember that it is very common for one vertebral artery to be smaller as compared to the other side, which is a normal variant. Rarely, vertebral artery can also be, completely, might be absent actually. It might be thread-like, and you on imaging, it might be absent. But having said that, these sequences, which were T1 fat, fat saturated, they really help you to see what is happening inside. This is a time of flight MRA, which also showed you the same thing. But on this, you will never be confident if that dissection is there. And another point here is that this is time of flight MIP sequence, where as I told you in the beginning, you can see on the right side, you can see the common carotid, then the internal carotid, and the external. This one is slightly actually rotated, so that's why the configuration is slightly different than what I taught you on the first film. Having said that, the main point to remember is look at the vertebral, and the vertebral will always be medial to the common carotid or the internal carotid. Look here, this is the common carotid and this is the vertebral, so it has to be medial. So here it is completely missing. I and an examiner can show you just this time of flight, and you should pick up that the vertebral is absent here. Yes, please.
Selected DSA of the carotid artery. I'm just looking at, there is some tapering of this carotid, this tapering of internal carotid artery. I can see that there's a tapering of internal carotid artery, and then there's no further branches coming off it. And the appearance are quite suggestive of dissection, as we discussed earlier. There's no distal filling of it.
That's very good. So here you can see that this is the carotid bulb, this is the external carotid, and this is the internal carotid. So the key point here was that there is, tapered narrowing. And this tapering tells you there must be an intramural, hematoma sitting the false lumen, which is compressing it, and maybe a trickle of contrast is going in. So that's fine. So just recap, various kinds of angiographies for the exam. So time of flight carotid, we can do it, we do it, but it's not considered very good for stenosis, etc. Usually, when we do for stenosis, we do a MRA, which is contrast enhanced, and in that we must include the arch of aorta, the origin of the great vessels. When we do a CTA, we again, that is the principle, the origin must be visible. And in the exam, they might show you a CTA or an MRA in which the problem will be at the origin. So this is a axial CTA, and this, of course, is a DSA, digital subtraction angiography. As I told you, that it is all your choice. You can invert it and invert it into make it white, or you can make it dark. Yes, please.
So these are selected CT axial slices of brain, which is demonstrating a hyperdense focus on the left side near the origin of anterior cerebral artery. I'm just looking at the rest of. There's also another hyperdense focus at the bifurcation with the MCA would bifurcate or trifurcate. So there are two hyperdense foci. These are hyperdense or non-enhanced sequences. So these could well represent aneurysms.
What will you do?
On the so I will straight away do CT angiogram with the patient on the table. So CT angiogram confirms there's a very large, well circumscribed lesion at the bifurcation of MCA, in keeping with the aneurysm. It has not bled. Also on the right side as well, sorry, left side, there's a ACOM aneurysm, or an AC aneurysm, I would rather say, from the left anterior cerebral artery. So these are two unruptured aneurysm.
Okay. Please remember, these kinds of cases, they come in the exam very, very commonly. This is what I call observation case. Pick up a finding, ask, and find. Now, you have to understand this bit to be able to go back. You see, the classical sites of aneurysm, the most common sites of secular intracranial aneurysm is on this diagram. ACOM, anterior communicating artery, and the junction between ICA and PCOM, which is this one. Bifurcation or trifurcation, this one. Basilar tape, which is this one. There are other sites also, but these are the most common. And so if you go back to your case, you did very well. This was maybe the bifurcation of the bifurcation. This one is ACOM. This is ACOM. And you can confidently say it is ACOM because it is so common here. Few things here which you have to remember indirectly, because they can ask you what will you do next, and these things are important for you for your clinical practice also. CTA these days is the investigation of choice. CTA is to 95% for 2 millimeter. Time of flight MRA is not bad, by the way. 90% sensitive for 3 millimeter. Another thing for the exam is that if you see one aneurysm, keep looking, because 20% of patients will have more than one, just like your case. This is known as satisfaction of search. Satisfaction of search is something which in the exam they ask you again and again. So these days, the investigation of choice, if there is subarachnoid hemorrhage, is CTA, but the gold standard is DSA. We'll come back to this point. Here we have got some risks of rupture, etc. These questions have been asked in the exam. Examiner can ask any theoretical question. So you can just take a picture here. But the point is that because it was asked to somebody, I put it here. So it will be your luck if you are asked these kinds of questions, which are more theoretical. Last case for you.
Again, I've been presented with selected DSA of carotid artery, which is demonstrating secular outpouching from, so this is external carotid artery, internal carotid artery, at the bifurcation. So it's going to be most likely, just wondering, PCOM, would it be PCOM? No, sorry, ACOM aneurysm, because it's other.
Okay, very good. That's fine.
Yeah.
Thank you. Candidate 3, be ready. Thank you, candidate 2.
Okay.
Now, if you see here, this is the internal carotid ICA angiogram. This is the A1 segment ACA. This is the M1 segment. And here, so there is filling of the other sided ACA from here. And you can see it's a classical A-com aneurysm. And please remember that examiner will, this is easy and this is more difficult. So they will show you a lateral film. And on a lateral, you have to understand that this is where the ACOM projects. So that's why I'm urging you to, before the exam, just revise your anatomy. Is candidate 3 with us?
Hello?
Okay. Candidate 3, over to you. I'm just giving you a flare sequence. 77-year-old male headache.
This is a selected axial flare sequence of an MRI brain for an adult patient. There's an abnormality in the anterior right temporal lobe where there is a large low signal lesion with adjacent high signal within the temporal lobe. And no other similar abnormalities are seen. In this region, this could represent a giant aneurysm in the region of the temporal lobe.
Okay, so I have given you a DSA now.
Okay, so on
Does it
this,
confirm your diagnosis?
yes.
Okay, excellent. Now, giant aneurysms come in the exam very often. And remember that right now, because we are in the vascular world, it is very easy to say that this is a giant aneurysm. And you know, when you are in the exam and tumors, etc., you will confuse it with that. Giant aneurysms, by definition, are usually more than 2.5 centimeters. On MR, remember that the internal signals will be bizarre. Bizarre is the word. And why? Because they can show partial thrombosis. And this partial thrombosis can give you this kind of signal. And there can be edema, etc. And here you can see that this was the bifurcation, you know, the M1 segment, and this is that giant aneurysm. So the IC, what the mind knows, I'm showing you a few of them. Just describe it. This is another giant aneurysm, but having said that, can you just describe it?
So it's again a rounded lesion anterior to the pons, causing some displacement and distortion of the outline of the pons. The internal signal is quite heterogeneous with areas of high signal mixed with low signal. There's also possibly some surrounding edema in the pons itself.
Okay. Now, on a contrast enhanced MR, you can see that what is happening inside. Can you describe it and what do you think is happening? What do you?
So on the contrast enhanced sagittal images, we can see that there is high signal likely to be contrast within the abnormality, in addition to areas of low signal more anteriorly, which may represent thrombosis.
Yeah. So bizarre is the word. Now, if you see here, there was a lot of mass effect on the brainstem, the pons actually. And look at the signal. It doesn't make sense, you know. And then on contrast, you can see part of it is enhancing, part it is not enhancing. And the explanation, as I told you, is because of partial thrombosis. Yes, please.
So These are selected unenhanced CT images of the brain for an adult patient. I can see an abnormality in the left, I think internal carotid canal, where there is expansion secondary to a large mass.
What will you like to do next?
Give contrast. Okay, so on these volume images, I can see that there is what looks like an aneurysm in the region of the left cavernous sinus.
So means it is arising from?
I think it's arising from the ICA.
Which portion of ICA?
The cavernous portion.
Excellent. So if you see here, now, this is what will happen. Last time, if you remember, I showed you 4 or 5 cases of pituitary adenomas. And those pituitary adenomas, some of them were extending into the cavernous sinus or the sphenoid sinus, etc. The examiner is always going to show it to you on an axial sequence. And in the tension of the exam, you are looking at whole of the brain, and actually the problem is here. Again, an edge of film type of a case for me. So if you see here, there was expansion, at least something is visible. When we gave contrast, by the way, I have given you CTA images, and and look at the window also. So you can see this vascularity. Now this is for orientation the best sequence, where you can see this subarachnoid portion here, MCA, ECA, and this is that cavernous portion of the ICA. Now, cavernous sinus or parasellar masses is a very important differential for the exam. Last time also, we have done a few pituitary macroadenoma, meningiomas, etc. And but you remember I showed you a schwannoma also in that region, Meckel's cave. Now, this is where we, vascular, carotocavernous fistula, aneurysm, cavernous sinus thrombosis. All of these we are going to see today. So, this is an aneurysm of the cavernous portion. Just to make a point, this is a giant, aneurysm of the cavernous portion of internal carotid artery. What is the time? Okay, let me crack on. I'll finish with you, and then we'll give you a break. Over to you.
Okay, so these are selected unenhanced CT images of the brain for a 69-year-old female. There are 2 striking abnormalities, one being a midline low-density lesion, which could be of fat or air, presumed to be an interhemispheric lipoma. Another abnormality is seen in the region of the right temporal lobe around the internal carotid artery, where it segments into the middle cerebral artery. It's a rounded, high-density lesion, which appears to have some possible peripheral calcification. I'm not sure if that's just projectional. That's most suspicious for being a large aneurysm, possibly an NCA.
What will you like to do? What will you like to do?
I'd like to give contrast, do a CTA.
Okay, so first of all, as far as your low density areas are concerned, you picked up very well. If you see here, low density, low density, low density, and then goes it. So this is a classical lipoma of the corpus callosum, and so it is going around the corpus callosum. And on this, in the exam, you will ask for, Hounsfield unit, and you can check it, and you can see that it was fatty density. But this is with contrast, and your conclusion is?
It's an MCA aneurysm.
Okay, and it might be on these axial slices. It's a very difficult to be absolutely sure because the aneurysm is very, very big.
Yeah.
Might be at the junction of MCA and the PCOM. But the main point here is I'm showing you cases which, these are two different findings. This is an incidental finding. And if you don't know how to pick up a lipoma of the corpus callosum, you will struggle through it. So this is another case which is observation case as well as, what we call the satisfaction of search case. So, yes, please.
Okay, so these are selected DSA images for a 31-year-old patient. There is an abnormal appearance in the, I think it's the left-hand side, where there are multiple abnormal-looking vessels, which give the impression of multiple small collaterals filling, possibly arising from the MCA. I think I've only seen this pattern with an AVM.
So in your description, one of the key thing which you must mention is, arteriovenous malformation. Your diagnosis is correct. But the key thing is arteriovenous, right? So there has to be a shunt. Now, in this arterial phase, you can see that this is MCA, maybe the M2 or M3 segment. And then you can see this venous connection. So part of the venous sinuses are highlighted. So that is a key thing in your description. Now, AVMs, arteriovenous malformations, are, as the name tells you, these are in between, there is no brain tissue. These are abnormal vessels. Usually the classical presentation is a bunch of worms type of appearance. And they can present, in sometimes on an MR, they might present as a filling defect, filling void. And on a CT, non-enhanced CT, they are going to show you, nobody is going to show you this kind of a scan. It's too easy. So initially, this might be a second film, but they will show you a subtle type of an appearance on a CT, non-enhanced. You pick it up and then they take it further. So these are, what I'll do is, let's stop here. And I'm going to give you a break now. It's a 5-minute break. And after break, we will start from here. Candidate 3, you are still with me. You will continue with me. Thank you. Us?
Yep.
Okay, so let me just recap here that the vascular malformations, this is from your last Chapman, arteriovenous malformation, they will only show you in the exam if the presentation is subtle. I am going to show you a case. But otherwise it becomes a very easy film. So nobody is going to show you unless it's subtle, non-enhanced CT followed by an arteriovenous AVM. Dural arteriovenous fistulas. Now, dural arteriovenous fistulas, two scenarios. In the real world, actually, dural arteriovenous fistulas occur because of various kinds of etiologies. For example, venous sinus thrombosis, etc., chronic. But having said that, in the exam, the only dural arteriovenous fistula which has come in the exam previously and which is important for you is a carotocavernous fistula post-traumatic. I'll show you a case. Now, cavernous angioma, also known as cavernous malformation or cavernoma, is extremely important, very, very popular in the exam. We will, come back to this case. And then is the developmental venous anomaly. Developmental venous anomaly, also known as DVA. Interestingly, about 20% of cases of cavernous angiomas, they can occur with a DVA. For cavernous angioma, on an MR, you can diagnose without contrast. But for associated DVA, you have to give contrast, and this becomes a viva type of scenario, which I will show you. Cavernous angiomas can be quite symptomatic at times, but DVAs usually are not. So we will come back to the details of these ones. Now, as far as AVM is concerned, this scenario you have to remember for your viva. Now, if an examiner shows you a interrupted internal hemorrhage, particularly in a child, you have to go back and there must be an underlying AVM, and for that further imaging will be required. AVM have got an annual bleeding risk of 2 to 4%. This is, self-explanatory, and there can be aneurysms also associated with, these AVMs. Yes, please. Candidate 3.
These are selected MRI sequences for, I believe, an adult patient. There is a large abnormality in the region of the left occipitotemporal region, where there are multiple filling signal voids, serpentine fixed signal voids, most likely in keeping with an vascular malformation.
What will you like to do?
Review the rest of the sequences, possibly consider some sort of angiographic study to confirm the finding.
Yeah, so initially you can just ask for a contrast enhance, just because a contrast study, maybe a CT or MR, this is an MR, will show you an AVM. But of course, for planning and for, planning of treatments, etc., you have to do a DSA. This is a DSA, but don't ask for a DSA. In this scenario, just ask for a contrast. Now, please remember, AVMs, they are devoid of any mass effect. So you can see this brain and there is no mass effect there. Okay, candidate 3, thank you very much. Candidate 4 is going to be the next. This case I'm going to tackle myself, just to make a point that this was an AVM on a non-enhanced CT. You can see this high density serpentine type of shadow. You give contrast and it becomes evident. Now, case 208 is the type of case of AVM which will come in your exam. So let me show it to you. Candidate 4, are you with us? No.
Hello, yes, I am.
Okay, now can you see my screen? Can you confirm that you can see a CT scan on your screen?
Yes, I can.
Okay, so I'll take you through this case, and this is the type of case you are expecting in your exam. Now, when the examiner opens it, it's a CT scan and it's an axial slice. And you are going through right and left what is happening. Now, if you see here, something has come into the view. Something has come. Definitely something is there. And now on this slice, it is quite impressive. So, and then here, it is, going right and left. Now, if I show you coronal, it becomes much easier to see. And you can see this high density here. You can see this, bunch of worms type of appearance. And then you can see that it is going all the way here and actually is draining into the venous sinus here, superior sagittal sinus. And on this MR, you can see this filling defects, and you can see how it goes and connects with the superior sagittal sinus. So the point is that anybody who shows you an AVM will show you initially on a CT scan. It will be a subtle finding, and only then will show you something else. So this is an MRA of the same case. Now, candidate for case 208 is on the slide in front of your eyes, blue slide.
Yeah, it is.
So this is your case now. This patient is post-trauma. What happened was that the patient is 3 days after subdural evacuation on base of skull fractures. So I am not at all interested in, you can see a bit of residual hematomas, and on bone window there will be some fractures also. I'm not interested here. I'm not interested here. Okay. This is a CTA study. Over to you.
Okay, so selected axial CTA slices. So having a look at the left superior ophthalmic vein, it appears slightly expanded and enhancing, which would make me think of a carotid cavernous fistula. Having a look at the cavernous sinus now. So I think there's possibly some gas locules in the expected area of the cavernous sinus, and the left cavernous sinus is slightly bulged or expanded.
Okay, I'll show you a corona.
Okay, so selected coronal images. So again, I can see the left superior ophthalmic vein is enhancing on the CTA, and having a look at the remainder of the vessels.
So how do you explain this finding?
So I think it's a carotid cavernous fistula, essentially.
Okay, very good. Okay, fine. Now, if you see here, the point here is that it was very well picked up that on this CTA study, you can see this is the level of the optic nerve, just superior to the level of the optic nerve. This vessel here is the superior ophthalmic vein. On a CTA study, you can see the basilar artery also here, and you can see the cavernous portion. You should not see this vein, and it is definitely much more prominent. With this kind of history, a carotocavernous fistula comes to the mind. On a coronal, it is confirmed. You can see that, look at the superior ophthalmic vein, it has got ramifications, tortuosities, it is very prominent. Has to be a fistula there. So, this is another case of carotocavernous fistula. Can you describe the findings? What kind of procedure has been done? Over to you.
So this is a catheter angiography of the anterior circle of Willis. I can see contrast going up the right internal carotid into the right MCA, ACA, and coming out on the, with contrast in the left internal carotid artery. Having a look at the lateral projections, or having a look at the more delayed image, I can see some contrast or pacification on the left-hand side in the expected location of the superior ophthalmic vein. So there appears to be early enhancement of the left superior ophthalmic vein with the possible connection with the left internal carotid artery, the cavernous portion of it.
That's fine. So here what has happened is that we have done a ICA catheter angiogram. Contrast has gone to the contralateral side through the ACOM. And here, once it went into the cavernous portion, it just went wild, and it went into, it highlighted whole of the sinus itself. And then this vessel, the only thing which can explain it is the superior ophthalmic vein. So this is another case. So carotocavernous fistula post-traumatic, it has come in the exam in the past also. Yes, please. So this patient is a young patient, 27 years old. She presented with repeated strokes in the past also. Ultimately, an angiogram was done. This is the picture on angiogram. Over to you.
So this is selected direct catheter angiography through the right internal carotid artery. There appears to be increased vasculature with fraying of the vessels, and they appear to be of more narrow caliber than expected, with possible vascular proliferation. This is giving a smoky smoke appearance, and with a history of a 27-year-old patient with repeated strokes, my first differential will be Moyamoya syndrome.
What is Moyamoya syndrome? And what is Moyamoya disease?
I think you can get Moyamoya syndrome from, it can be an end result of multiple vascular injuries. And I think Moyamoya disease is the primary form of the, it's a sort of vascular anomaly, arterial anomaly, where you get multiple vessels which are multipliable.
Do you want to use the word disease here or syndrome here?
Disease, Moyamoya disease.
Okay, good. So let me take over. Now, Moyamoya disease is a disease in which what happens is that there is stenosis of supraclinoid arteries, supraclinoid portion of internal carotid artery, the MCA, the ACA, even the PCAs, etc. can be involved. Just remember that large intracranial vessels are involved. Moyamoya is a Japanese word, which is puff of smoke. And this is on angiographic pattern. In this particular case, if you look carefully, what is happening, that this is the ICA. Now, if you ask yourself, where is the ACA? Maybe portion of the ACA is visible here. Where is the MCA? Portion looks quite stenosed. And there are many collateral vessels here, many collateral. On a slightly delayed angiographic phase, you can see this puff of smoke appearance on this arterial. This is just late arterial phase. So this is classical for Moyamoya. Now in Moya, this disease was initially described in Japan, and puff of smoke is the word Moyamoya. It will be bilateral finding, And these patients will be, they are children actually. They present as children. And because it is developing over time, they develop a lot of collateral vessels, which give you this puff of smoke appearance. Later on, people saw that this kind of pattern is also seen in other chronic illnesses like erythematous diseases, etc. We call it Moyamoya syndrome. Some people call it Moyamoya pattern also. So having said that, Moyamoya disease will be bilateral and it will be children or young adults. Look at this case. What is the finding here?
So, this are spot images from an MRA image, and I can see focal areas of concentric narrowing in the circle of Willis, and there's some smooth tapering of the vessels, specifically the internal carotids bilaterally, with some proliferation of surrounding vessels in keeping with Moyamoya.
Thank you, Ram.
So this is an direct catheter angiogram from the internal carotid, and again I can see a proliferation of vessels which appear to be of abnormally narrow caliber, giving a puffy smoke appearance in keeping with Moyamoya disease.
Okay. So in this case, on this MRA study, you can see that the large vessels, if you see the subarachnoid internal carotid, where it is gone, AC is gone, proximal MC is gone, you can see a bit of vessels here. And similarly on the left side also. And this gives you this puff of smoke appearance. Don't think that Moyamoya disease is just, a Japanese disease. In my hospital, we have got 3 patients. And I'm showing you the study of one of the patients. Look here. This, you can barely see any big vessels inside. Just, bunch of on this MRA. And this patient has presented with multiple strokes. Look here, chronic strokes. And this MR is in my collection when the patient was 29. At the age of 32, unfortunately, she expired. So this is Moyamoya. And sometimes you can get, this prominent arteries in the basal ganglia, which makes sense because these are the lenticulostriate arteries, which might become very prominent. And this can happen in Moyamoya. Yes, please.
So these are selected, unenhanced, and post-contrast images of CT head in a 3-year-old patient. So on the post-contrast, there is a circular vascular density between both ventricles, where I would expect the vein of Galen to lie. This is causing significant secondary hydrocephalus with dilatation of both the frontal and posterior horns. Having a look on the image on the bottom right, I think I can connect this bulb-like structure to the straight sinus more posteriorly. So my findings will be in keeping with vein of Galen malformation.
Okay.
I would probably confirm this by doing a catheter angiogram. So selected catheter angiogram through the posterior cerebral circulation confirms a large aneurysmal structure of the vein of Galen, which is massively dilated. This confirms the finding of vein of Galen malformation in this patient, I would refer to neurosurgery given the significant hydrocephalus that this is causing.
Okay, fine, good. Now, let me go back. Let's revise a bit of anatomy, which will help us understand this case. Now, if you see here, this is the superior sagittal sinus, and this is the inferior sagittal sinus. Now, two veins come from the thalami as well as the basal ganglia, where I am pointing out. These are known as internal cerebral veins. So they are coming from the thalamus and the basal ganglia bilaterally. They join together. And they join together to form this great cerebral vein, also known as the vein of Galen. Two other veins, which are the basal veins, they are at the level of the midbrain. They also join. These are not important for your exam. Vein of Galen, this anatomy, internal cerebral vein, and vein of Galen is very important for two cases in the exam. One is vein of Galen aneurysm, and second one is dural venous sinus, internal cerebral vein thrombosis, which we will come back to that. So vein of Galen joins the inferior sagittal sinus to make the straight sinus, and it goes and joins the superior sagittal sinus. This is the confluence of sinus. From here, it becomes the transverse sinus, and it dips down. Here is the sigmoid sinus and the internal jugular vein, sigmoid sinus, internal jugular vein. Anteriorly, of course, these are the cavernous sinuses, and there are also cortical veins right and left. So, vein of Galen malformation is actually vein of Galen aneurysm is what we call it usually. It's a misnomer because this is a vascular malformation and arteriovenous shunt. What is happening is that there is shunting of blood and the drainage is abnormal. The vein does not drain properly at times. In this particular case, the vein is dilated. It is going into the straight sinus, and you can see vascular malformation here. Now, these patients, these babies, they present with CCF. And on the other hand, if it is not as blatant a case as this one, you can even see vein of Galen aneurysms in advanced, more advanced age groups, even in adults. Even in adults, you might be able to see. This is another case where you can see this flow void here, and this one, there is drainage into the superior sagittal sinus. There is no straight sinus here. So this is another vein of Galen aneurysm. Okay, this is last case for you, candidate 4, and candidate 5 should be ready after this. Over to you.
Okay, so these are selected T2 axial images of the brain, and there are multiple foci demonstrated predominantly on the left cerebral hemisphere. There's one in the left temporal lobe, frontal lobe, and also in the pons. The lesions all demonstrate a similar characteristic of heterogeneous T2 signal centrally with peripheral rim of low T2. Findings where has a typical popcorn appearance, and findings are most likely in keeping with cavernomas, given the lack of edema surrounding these lesions or mass effect. This will be my most likely diagnosis.
What would you like to do?
So a small proportion of cavernomas are associated with developmental venous anomalies. So you can do a CTA to see if there's any
CTA?
MRA or CTA to see if there's any associated anomalies.
Okay, actually, you don't need to do a CTA or MRA. You do a contrast enhanced MR, simple as that. So, and on the contrast enhanced, the developmental venous anomaly will be seen. Okay, thank you very much, candidate 5. Now, before I give you a case, let me go through cavernous malformation for the exam. Cavernous malformation is one of the most popular cases for the exam as far as vascular malformations are concerned. And cavernous malformations, also known as cavernoma or cavernous angioma, basically it is, blood vessels which are also known as caverns, and the walls are not, very robust, and they do bleed. Very interesting behavior of cavernomas. They can enlarge, they can regress, and they can, de novo formation. Means you have done a scan 1 year and there was nothing, and 2 years down the road, you can see a cavernoma. And so don't think that it is something malignant, but this is how they behave. Age of presentation is, anywhere between 40 to 60. Of course, it can be younger also. So the appearances have been described, 4 different type of appearances have been described. Basically, the most, the smallest cavernomas will be simply low signal on T2 star, as in gradient echo or SWI sequence. But larger ones will have, various kinds of bleeds inside, and they give a popcorn appearance. Classical appearance will be popcorn appearance with a hemosiderine rim, complete rim of hemosiderine. And this complete rim of hemosiderine will be low signal on T2 weighted sequence. Viva tip is you have to ask for a contrast enhanced MR to rule out a DVA. The cavernous malformations or cavernomas themselves, they might not show any enhancement. They might show subtle enhancement also. But that is not the point. The main point is that you have to pick up a DVA. Cavernomas can be very symptomatic. People can present with seizures and so many other neurology. And at times they have to be treated. And for that, microsurgeries are used, gamma knife treatments are also used. The idea to diagnose an associated DVA, as in developmental venous anomaly, is that the DVA should not be disturbed, because if the DVA is disturbed, there might be venous infarctions. So that is the idea. Candidate 5, are you with us?
Yes.
Okay, over to you. 42-year-old male.
So I've got multiple axial slices T2 and T1, on which I can see that there's an abnormality anterior to the frontal horns of the lateral ventricles, which on T2 is centrally iso-intense with a surrounding dark rim. And then on the T1 appears bright with a central area, which is iso-intense. So it looks like with the rim, it looks like it's a vascular anomaly in that region, centered anterior to the frontal horns.
So anatomy-wise, where is it? I want to hear a name.
So anterior.
And a hint, it is crossing right and left.
Corpus callosum.
Excellent. So this is the genu of the corpus callosum, and genu of the corpus callosum is a known location. Usually, you are taught that only GBM and lymphoma, they cross the corpus callosum. Here you are, it's a benign lesion, cavernoma. The key thing here is the hemosiderine rim. And if you see this T2 weighted sequence, it is a complete rim. Internally, there is other types of hemorrhages, which are subacute, etc. This is that classical popcorn appearance. But the hemosiderin rim is, there's a very good predictor of benign versus malignant lesions. When there is a complete hemosiderin rim, you are very confident. So this is a cavernoma. Yes, please.
So again, I've got a axial slices of a CT in a 36-year-old. I think the ones above are non-contrast and the ones below.
This is all contrast. This is all contrast with contrast.
Okay, so post-contrast, and I can see that in the, again, in the splenium of the corpus callosum.
Your splenium, maybe. Okay, here's the splenium. No, don't worry about it. Anything else?
And then on the top images, on the right side, in the right cerebral hemisphere, just see some.
So what is this?
So this looks on the angiogram, so this is enhancing uniformly, and I can't see it on the lower slices, so it's above, just at the level of the lateral ventricles in the right frontal, but it's quite well defined, and I'm trying to think what anatomic location it's confirming to. It's doesn't
your
show.
thinking is right. It's a very, very, straight line type of a structure.
Yes, I'm just thinking whether it's.
So I've given you an angiogram of the same case, and you have got an arterial phase and you have got a venous phase. Over to you.
Okay, so on the venous phase, it almost looks like what I was looking on the CT. It appears to be in the right frontal, and I can't appreciate that area on the arterial phase, but on the venous phase, just below the superior sagittal sinus, I can see there's a well-defined linear structure. Whether this is a cortical vessel, an aberrant vessel.
Yeah. So what do you call it?
Is it because it's on? I can see it on the venous, so it would be an aberrant cortical vein.
Not cortical. It is in the parenchyma, right? Okay, fine. It is this is what we call a developmental venous anomaly, also known as DVA. Now, look at this concept. Basically, there are multiple small veins, and these veins are within the white matter. And from there, they will drain into a large vein, a large anaconda, I call it. And this large vein can drain into one of the cortical veins, or maybe ultimately, in this particular example, going into the superior sagittal sinus. Or they can also drain into the ventricle. So, subependymal vein. So either they will go here or they will go outside. This is known as Medusa head sign, where there, this is Greek mythology. Medusa had a lady with a lot of snakes on the head. So if you go back and see your case here, this is another example of the eye see what the mind knows. Straight here, and you can actually see two odd small snakes here with a larger snake here. And this is an arterial phase, you don't see it. On the venous phase, you can see all of these snakes, this Medusa head sign. And they drain into one vein and then go into the cortical vein. So 20% of DVAs have bought existing cavernomas, and cavernomas are best seen on SWI or P2 star sequence. So interestingly, when you pick up a cavernoma initially, you can ask for SWI in P2 star to pick up multiple, smaller cavernomas which are not visible on other sequences. On the other hand, if you see a DVA, and then you ask for a contrast examination to pick up a DVA. But if some examiner shows you a DVA initially, then you again ask for a SWI or T2 star to look for cavernomas. So you should know the relationship between the two and which sequence is best to pick them up. As I told you, cavernomas can be very symptomatic at times. So these kinds of cases I've shown you in the past, where you can see on T2 star, you can see multiple low signal intensity foci. Now, it can also be, the differential diagnosis, multiple cavernomas in a slightly advanced age group, cerebral amyloid angiopathy, hypertensive encephalopathy. But then in these two entities, you will also see white matter changes, which are not seen in this particular case. Please also remember that multiple low signal intensity on SWI sequence or T2 star sequence has got a differential, which we covered in the first session, DAI, etc., multiple septic emboli, etc. So I'm going to skip it today. Okay, this is a 12-year-old presented with headache, T1 weighted, T2 star, T2, post-contrast T1, post-contrast T1, post-contrast T1. Over to you.
So I can see on these selected slices that on the T2, on the T1 weighted, I can see there's a fleck of low intensity posterior to the fourth ventricle. And then on the T2 star, I can see that there is a signal loss in the right and lateral to the right ventricle, which does show some enhancement on the post-contrast sequences. It's a solitary lesion. The rest of the brain parenchyma appears unremarkable, and so this is most likely to be a thinking a cavernoma or it's not behaving like a cavernoma.
Why do you say it's not behaving like a cavernoma?
I'm just thinking it's quite close to the fourth ventricle, and
so that is not a discriminator. Cavernomas can be anywhere.
Whether they've got a cavernoma, and I think whether they've developed a DVA as well, because on the post-contrast,
yeah, that's fine. So they associated with a DVA. Basically, what is happening here is that on this there is a cavernoma. With that, you can see this DVA, which enhances, and now carefully you can see it goes out. This particular cavernoma is also showing a bit of enhancement. Please remember that cavernomas can show a bit of enhancement at times, and at times they will not. Do you see a cavernoma here on a CT scan?
Yes, it's on the right side, just over the right level, the level of the pons.
Medulla, actually.
Yeah.
Right?
Yeah.
So this is the pons and this is the medulla. Now, this is a type of case which will be very difficult for you in the exam, where on a CT scan, usually you don't see cavernomas, but please remember that cavernomas can cause hemorrhage, internal hemorrhage. Within the lesion there can be hemorrhage. So that will be high density. And look at this one, and it is here. It is just at the medulla where it is. So this is a type of case which will be, for observation. And when you do T2 weighted, MR for this, the examiner will, what will you do? I will do a MR. And on MR, you can see this susceptibility weighted image. Actually, on this T2, you can see sort of that popcorn type of an appearance. And you can see it here also. So this is another cavernoma. Okay, classical exam film.
So again, on these non-contrast axial slices, I can see high density in the posterior sagittal sinus. There's no acute intracranial bleed that I can see, and there's no evidence of any infarct. So I think this is most likely in keeping with a sagittal sinus thrombosis.
So the word which you used was, which sinus? Which sinus it is?
The posterior. So I meant the sagittal sinus, but posterior.
So, the sagittal sinus can be superior sagittal, it can be inferior sagittal.
Superior.
Okay, if you see here, now this is a very, very nice exam case of, venous sinus thrombosis. Venous sinus thrombosis at times can occur where the sinus will have a thrombus which will be high density. So on a plain film, you have to pick up. Now, in this particular case, if you go back, you remember that this is the internal cerebral vein. Both of them, they join together to form the vein of Galen and then the straight sinus. This is the superior sagittal sinus. This is the inferior sagittal sinus. And this is the straight sinus. So you can see that this is thalamus, this is thalamus. You can see one vein here, stretch of imagination. This has to be the internal cerebral veins. And then they join together, so the vein of Galen must be here, and then it goes into this straight. This is the straight sinus. Here you are at the superior sagittal sinus. So this anatomy is important. Now, in this particular case, we did an MRV for this case. This patient was an alcoholic. He came with headache for about 6 weeks of duration. The MRV is not very good. Quality-wise, he moved a lot, but you can see practically all the sinuses are thrombosed. In any case, this is an exam fail. What is this sign?
So this is the empty, the delta sign.
Excellent. So empty delta sign is a sign which on CT with contrast, this has to be with contrast, you can see that there is a filling defect and the dura surrounding it is enhancing, giving you this empty delta sign. So in keeping with superior sagittal sinus thrombosis.
So again,
classical scenario which happens in day-to-day practice. You do an MR with MRV, and the patient's history is, for example, the patient is pregnant. They're worried about sinus thrombosis. So in this particular case, the MR sequences were okay. There was nothing wrong on the MR. But on the MRV sequence, what is your conclusion? This is the finding, and what is your conclusion?
So I can see there's non-opacification on the post-contrast sinus on the left side of the transverse and sigmoid sinus, in keeping with the left transverse and sigmoid sinus thrombosis.
Now, this is a known pitfall which can happen, and the pitfall is because of anatomy. About 16% of transverse sinuses, they might be what we call hypoplastic, and at times they are completely aplastic also. And this is a known pitfall for MRVs, and that is why people say that CT venogram is a better study than MR study. In these particular cases, I'm going to teach you tricks of the trade, should I say, to look for. What you do is that you look at a CT. Usually these patients will have a CT also on the pads. You look at the CT scan and go back to your embryology Now, this is the jugular foramen, and this is the jugular foramen on left side. So this is the jugular foramen, and this is the jugular foramen on left side. This is the sigmoid notch where the sigmoid sinus is sitting. This is the sigmoid notch on left side. This is smaller as compared to the right. And the jugular foramen, you can see, look here, this is the jugular foramen, and this is it, and it is much larger. And actually, this is what we call a high-riding jugular foramen. So, what does it tell you? It tells you, embryologically speaking, what has happened is that this patient, when was developing as a fetus, the right-sided jugular foramen is larger for the simple reason that right transverse sinus and internal jugular vein is larger as compared to the left. So the key thing is to remember that whenever you have got gout here, go back to your CT scan, which will be very useful to make the discriminator. And this is a normal variant. Please also remember that you have to look at the usual sequences. Usual sequences like, for example, this is another case. This is not the same case where there is, this high signal within the superior sagittal sinus, which is a filling defect on post-contrast. So this is, a sort of a absolute slam dunk type of a case. Candidate 6, can you hear me?
Hi.
You can hear me?
I can, yes. Thank you.
Okay, now what do you think is happening here? And then look what is happening here.
Okay, so these are sequential, there are several sequences in this 34-year-old female patient's brain. The most striking abnormality is the presence of a spherical lesion with heterogeneous signal intensity in the right temporal region, with associated high fluid signal surrounding it, indicating edema. And looking at the second row, there's a linear high signal intensity in the posterior aspect of the right cerebrum, in the cortex. So putting the two together, I think this patient has got a cavernoma and an associated possible DVA as well.
Okay. You see, this is a case of cavernomas, DVAs, they will not cause this kind of edema. This, high signal within the sulcus is subarachnoid hemorrhage. And you have seen this kind of case initially. This, can you imagine this is only 34-year-old and this is a giant aneurysm. And this is the bifurcation of the MCA with bizarre signals inside. And then this edema, but I wanted you to, particularly concentrate here. Look at these sulci and you can see this low signal within the sulcus, which is CSF. Here, it is less partly because of edema, but look at this line here, means subarachnoid hemorrhage, which has gone in. So this case was confirmed on a CTA. On this contrast enhance, you can see a bit of thrombosis, etc. I'm going to skip the CTA because of time factor, but this was a giant aneurysm. You have already seen it. Do you see subarachnoid hemorrhage in this case?
So there is increased density on the CT in the Sylvan fissure on the left. So I think there may be some subarachnoid hemorrhage over there.
Okay, good. It's a subtle finding, definite finding. There is a bit here. If you see here, this, this is the fox. This is CSF here and maybe obliterated here. But this is a definite finding and then something here. Fine, well done. Now, what is the cause of this subarachnoid hemorrhage? Give me the cause.
So it's in the, well, it's quite florid, but the epicenter seems to be in the perimesencephalic region. So it could be a perimesencephalic hemorrhage, subarachnoid hemorrhage.
You see, perimesencephalic hemorrhage is what we call a venous hemorrhage. Now, we'll come back to that. I've got a case there. But it is absolutely gross subarachnoid hemorrhage. It is, everything is involved. Prepontine cistern, CP angle cistern, everything around the midbrain, ambient cistern, interpedunculair cistern, Sylvian fissure, and it goes on up to here. What is happening here?
So there's a non-contrast study, and there's a globular structure in the midline that is likely to be a large aneurysm which has bled.
So anatomy-wise, where is this aneurysm sitting?
So this will be in the basilar tip.
This is not, you see, this is the territory of ACOM.
Yeah, apologies. Yeah.
ACOM, right? This is a classical exam case, and they will ask you, what is the cause? When there is a thrombus sitting at this, you just, say that this is in keeping with ACOM. Of course, you would like to confirm it. That's a second thing. What's happening here? Over to you.
So there are multiple areas of high density within the cell side, bilaterally, and more prominent on the right actually. Hello?
Yes.
Sorry, I lost my microphone.
Yeah, actually there was a hissing noise coming. So in any case, please continue now.
Yeah, so these are sequential CT slices in a patient. There's the high density within the cell side throughout the brain actually. And it's slightly more prominent on the right side. And if this is a young patient, I think I'd be concerned about hydrocephalus because the temporal horns are quite dilated. I'm looking for a cause of the subarachnoid. I think it's a subarachnoid hemorrhage, which is quite florid. And I'm looking for a cause for that. The trochlear appears quite dense. I wonder if there's a thrombosis there possibly.
Okay, I'll take over because of the time factor. This is a very, very good case, and these kinds of cases have come in the exam quite a few times. My personal students, my own SPRs have got them in the past. Basically, what is happening here is that there is no subarachnoid hemorrhage, there is leptomeningeal enhancement. And it's bilateral symmetrical. And actually, the key thing is look at the basilar artery, and then you understand that this is with contrast. Basically, I just put it here just as a trick case. But in the exam, the same thing will happen. So don't jump to conclusion. Is it, you remember the flare sequence where you have to differentiate between giving contrast, is it leptomeningeal versus subarachnoid? Similarly here on the CT, they can show you as a trick case. This is with contrast, and once you pick it up, it is with contrast. There is bilateral symmetrical leptomeningeal enhancement, you can see, look at these sulci and look at these sulci, these are effaced, means more edema on this side. And then you come to the differential, which can include, things like TB or fungal infections or carcinomatosis. We'll come back to similar cases in infection. Now, this is a case of perimesencephalic subarachnoid hemorrhage. Perimesencephalic subarachnoid hemorrhage is slightly different. Now, look at this history. This patient, while doing push-ups, then reported a headache, and you can see subarachnoid hemorrhage around the pons and the midbrain. In perimesencephalic hemorrhage, what happens is that there can be more hemorrhage than what I show you on this case, but having said that, this is more classical. Now, to differentiate it with subarachnoid hemorrhage, because of a ruptured aneurysm, etc., you have to do more imaging. And what I'm telling you now are all Viva questions and Viva concepts. When you receive a case of subarachnoid hemorrhage, you do initially you do a CTA. And please remember, Viva questions can also go into the territory of LP, because a CTA is about, to pick up an aneurysm, about 97% sensitivity is there. But, if clinically speaking, you are absolutely sure, you are very worried, and the CT does not show a subarachnoid, you can do an LP and send the sample for RBC count as well as xanthochromia, which is bilirubin. So that is considered a gold standard. So this can be a Viva question. But once a CTA, if a CTA gives you an aneurysm, you have got your diagnosis and you send the patient to a tertiary center, or if your center is a tertiary center, to treat it, and they will do a DSA and then do treatments. On the other hand, if the CTA is negative, you don't stop there. Then you do a DSA. And if the DSA is also negative, usually you do what we call a 4-vessel or a 3-vessel DSA, in which in the vertebral, if the other PCA is also shown, if it is a 3-vessel. Otherwise, classically, you should do a 4-vessel DSA. So, when you do a 4-vessel DSA and there is no aneurysm, what does it mean? It can still mean that there is an aneurysm which is not visible because of 2 reasons. What can be the 2 reasons? Either there can be spasm of the vessel or there can be thrombosis of the aneurysm. So classical teaching is repeat it after 7 to 10 days. So I take you back. When there is subarachnoid hemorrhage, do a CTA. If the CTA is negative, do a DSA. If the DSA is negative, repeat the DSA in 7 to 10 days. And if it is still negative, then you have got, in this particular case, you have got your diagnosis, which is benign subarachnoid hemorrhage. There are a few theories, and most people think that this is venous hemorrhage. So this was the same case in which the DSA, etc., was normal. In this particular case, is there an acute infarction? Now, we are going to quickly see a few cases of acute infarctions. Yes, and this is your last case, by the way.
Okay. So these are 2 axial CD slices, and on the left MCA territory, in the left MCA, there's hyperdensity, which is in keeping with a likely left MCA thrombosis. I don't see any current count changes as yet, but I will look through the rest of the imaging to look for that.
So hyperdense MCA you have picked up. Did you pick up anything in the basal ganglia?
So yeah, in the right hand image, there is obscuration of the insular cortex, which is in keeping with a left MCA infarct as well, earlier left MCA infarct.
The point is that this is the lentiform nucleus. That lentiform nucleus has become hypodense here, so there is loss of gray-white matter differentiation. Regarding the insula, maybe you are pointing out to this insula. Actually, I have not given you adequate slice through the insula. We'll come back to this. Now, this particular case was 2 hours 15 minutes, and there was restricted diffusion on this, which shows that there is an acute infarction. Now, quickly, we are going to candidate 7. Please raise your hand. Now, quickly, we are going to go through cases of acute infarctions which can come in the exam. But before we do that, few signs which are important for the exam. Now, signs of acute infarction: subtle hypotension, obscuration of lentiform nucleus. This is one which we saw in the last case. Then loss of gray-white matter differentiation, insular ribbon sign. Sulcal effacement can be there. Hypodense MCA sign or MCA dot sign can be there. Now, basically, this is the anatomy which is important. This is the lentiform nucleus, putamen and globus pallidus. This is the head of caudate nucleus. And this is the internal capsule. This is the insula. Please remember that gray matter is higher density on the CT than the white matter. And when there is loss of gray-white matter differentiation, that is taken as a sign of early infarction. Candidate 7. In this case, on the right side, do you see any acute infarction?
Yes.
Okay. Can you describe it on this slice where I am pointing out?
Sure. So there is an area of low density extending out to the cortex in the right frontotemporal region with loss of the gray-white matter differentiations and some minimal sulcal effacement.
Okay. So if you see here, look at this. Look at the sulci, and the sulci are high density because that is correction the gyri. So these are high density because that is gray matter. And at this location, we lose it. At this location, we lose the gray-white matter differentiation, and again here. So stroke window or acute infarction window, whatever you want to call it. This window, those of you who don't use it in your clinical practice, you can use it. The window width is 8 and the level is 32. It gives you this kind of picture. Now look carefully here. This is the lentiform nucleus. This lentiform is high density. So it is white. This is head of caudate nucleus. This is the thalamus, which is again a gray matter. So this is high density. Now look here that basal ganglia is low density. So this window is very good to increase your level of confidence. This study tells us that the sensitivity increases from 57 to 71% if you use it. So in your exam, in your clinical practice, first of all, you have to develop your eyes to use it in your clinical practice. Then use it in your exam. You can ask the examiner that I will like to confirm it on an acute infarction window if it is a subtle finding. Where is the infarction here? Candidate 7.
So I can see an area of, it's a right occipital lobe.
Occipital lobe.
It's actually quite high. Parietal lobe.
Look at the insula, please.
So it's there's a right MCA dot sign.
Okay.
And
So what about the insula itself?
So there is a insular ribbon sign as well on the right side.
Okay. So if you see here, look at this insula, and this insula is high density. So the external capsule is low density. So there is gray-white matter differentiation. Here, the insula is low density equal to the white matter. So there is loss of gray-white matter differentiation. This is known as insular ribbon sign. With that, these arteries here, these arteries are, you know, the M2 segments of the and the M2 branches of the MCA, they appear slightly high density. So this is known as MCA dot sign. MCA dot sign for me is quite a rubbish sign, because you can make up your mind, you know, you can just call anything MCA dot sign. I don't give much leverage to this sign. On the other hand, hyperdense MCA sign, which is the M1 segment, that's a much better sign. In this particular case, if you go to the acute infarction window, and now you can see how beautifully that differentiation can be seen. Now, this is the insula, which is the normal insula. Look at this insula. This has become black. So this is insular ribbon sign. There was subarachnoid hemorrhage in this case. Is there an acute infarction? So right-sided hemiparesis means look at the left. Look at the left.
So I'm looking specifically on the left side now at the basal ganglia. I have an impression that is.
So I'll give you a stroke window.
Yeah, sure. So again, in the left insular region, there is an insular ribbon sign demonstrating with an acute infarct.
Yeah, here you are. Again, you can see the beauty of this stroke window, which increases your confidence. But having said that, if you see here, this was the insula, and you can see the insula here, and one can argue that the same thing is visible without the stroke window also. After 5 days, this is what happened. Is there an acute infarction? This is a classical exam case.
So there is loss of the normal sulcus, there's sulcus effacement on the left cerebral hemisphere.
You mean to say, okay, left, somewhere here?
The left side.
Okay,
Yeah.
left. No, don't worry about this. Anything else? Look at the occipital lobes.
Okay. So, I mean, the right occipital lobe has got a normal gray-white differentiation, but looking at the left side on the lower left image there is a...
What do you think now? Just concentrate on these two.
So, yeah, so the left occipital lobe is abnormal.
And why do you say that the left is abnormal? Because you go back.
Right, the right side is abnormal.
Right is abnormal. Now, you see, look at this case carefully. It's a very subtle one, a bit harsh, but a definite case. If you see, you know, look at this, these gyri, they are slightly high density. Now, if you see here carefully, there is loss of that gray-white matter differentiation. Very subtle. Just compare this area with this area. When you go to this window, then it makes it more clear. And after 24 hours, this is what has happened. So the point is that stroke window is quite a useful window to see it. This patient is for thrombolysis. What is your opinion?
So I'm looking specifically for any acute hemorrhage. I can see there is territorial infarction on the left side, and there's some high density within the ventricle, but that is calcification of the choroid plexus. I do not see any sign of hemorrhage on here.
So they want to thrombolize. Will you allow that?
So the thing is that the low density areas is in keeping with establishing evolving infarct. So it depending on the time of onset and the clinical presentation of the patient. But radiologically, I do not see any contraindication on these slices.
So, okay, the main point is look at the pattern of this edema, and this is a classical exam case. This is vasogenic edema. This is not cytotoxic edema which goes to the cortex. This is white matter abnormality. This is all, you see, look at the cortex. The cortex is absolutely fine. So this is vasogenic edema, and the answer here will be, I will be worried if there is something tumor setting there, and I will give contrast. In this particular case, there were metastases actually. And I'm showing you not a CT, but an MR. But the point is that vasogenic edema is the learning point here. So the cortex is fine. Okay, here, quickly, we are just going to do the territories. So the territories, if you see, we are talking about MCA territory, ACA territory, PCA territory, etc. Now, if you look at the right side, anything which is green, this green, this green, this green, this green is MCA territory. On the right side, this purple is the ACA territory, ACA. And they ask exam questions on this. Key thing to remember is anything which touches the fox. So here is the fox. Anything which touches the fox is ACA. And where is the PCA? This yellow is the PCA. Yellow is the PCA. Key thing is the posterior circulation. So the posterior circulation is the basilar artery. And PCA is, of course, part of the basilar artery. Key exam point is thalamus. Please remember, part of the thalamus is supplied by MCA and part of it is supplied by PCA. So in a PCA, in a basilar artery thrombosis, you might see the thalamus to be abnormal. Now with that background, just quickly, can you tell me the territory, which territory is involved?
Right MCA.
Say again?
Right MCA.
Right MCA. And is it going to the fox?
So part of ACA is also could be the...
So say that MCA as well as ACA.
Yeah.
Right? Which territory?
Left ACA.
Which territory?
Right PCA.
Which territory?
It's bilateral. It's bilateral. Could it be Vascular?
Excellent. So it has to be basilar, posterior circulation. And here is my point. Look at this thalamus, and part of it is involved. So thalamus has got variable supply, but remember that it will be usually a dual supply.
So
what is your diagnosis here?
So we got multifocal infarct, post-thoracic surgery. So it's cardioembolic infarct.
Excellent. So these are embolic, which do not, which are not confined to a territory. And you can see posterior circulation, you can see anterior circulation. Another thing with embolic infarcts is hemorrhages. So there can be hemorrhagic infarcts. Multifocal acute intercerebral hemorrhage, septic embolism. This is what can it be. So this is another case in which there was a post-mitral valve surgery And with that, you can see these micro hemorrhages. So these are septic emboli. These micro hemorrhages are low in signal intensity on the SWI sequence. This is your last case.
Sure. Unconscious.
Unconscious patient.
So I can see a dense basilar tip, so in keeping with basilar thrombus.
Excellent. Now, if you see here, basilar artery is your friend. It should be one of your, checkpoints for the exam. Look at one of the review areas, basilar artery. I've shown you a case of leptomeningeal carcinomatosis or ETB, in which it was enhancing, means that was with contrast. But basilar artery thrombus is a very important exam case. It will always be subtle. In this particular case, the learning point is that initially, pons, etc., you will always be in a doubt, because there is a lot of artifact from the petrous ridge, and you will always be, never be confident initially, is there an infarct there or not? Look at the thalamus, compare right and left. Even in this case, you can see that there is some hypodensity in the thalamus. So this increases your confidence. And this is the follow-up of this case. So you can now mute yourself. Candidate 8 should be with us. I am going to show you this case, and then candidate 8 will take us to the end.
Mute.
Okay, candidate 8, can you see these two cases of basilar artery thrombosis on your screen?
Yes, I can see them.
Okay, so I'll go through them. Now, if you see here, in this particular case, there is what we call, there is vertebro-basilar dolichoectasia, where there are dilated vertebral arteries as well as the basilar artery. But here, definitely, here you are a bit confused. Part of it, is there a thrombus or is there calcification? But as we come here, there is definite high density, and then it becomes normal density. And on a CTA, you can see, then the examiner will say, what will you do? And you will say, I will do a CTA. So this is the basilar tape. I'm going inferiorly, and you can see it just vanishes. So as we go up, no flow here, and then because of the PCA, there is a bit of flow. This was case 1. And case 2 is this one, where this is the basilar artery. And as we are coming to the tip, you can see this high density. And this high density actually goes into the PCA on the right side. And so something may be in this thalamus also. And then this is the stroke window. Look at this thalamus versus this, and you will agree that this is more hypodense. And then day 2, you can see that there is more advanced. And look at this thalamus. So that was Right. So candidate 8, can you see this case? CT scan?
Yes.
Okay, over to you.
Okay. Axial non-contrast CT head. Static image. There are bilateral symmetrical hypodensity in the lentiform nucleus. The globus pallidus appears to be more hypodense than the inner lentiform nucleus. So I'm thinking this could be a systemic cause, such as carbon monoxide toxicity.
Okay, so what is the differential diagnosis of bilateral basal ganglia abnormalities?
Systemic causes from toxicity will be my first differential. Carbon monoxide poisoning, lab poisoning, that kind of thing, methanol toxicity.
So you are going into the world of toxicity. Very good. Anything else?
I suppose you could have a vascular cause as well. I think, is it the artery of Percheron that could cause some bilateral infarcts?
Parkinon, okay, that will also include the thalami, actually, you are right. Okay, so, okay, fine. The idea here is to do the differential diagnosis for your exam. And this differential diagnosis is for, bilateral basal ganglia abnormalities. Your book tells you deep gray matter abnormalities. So gray matter, of course, thalamus is also deep gray matter. And these toxins are very important. Carbon monoxide, methanol, cyanide, I always laugh on it because we have always been told that cyanide poisoning will kill you in 2.5 seconds or something. In any case, who will do a CT there? But it is given in the books. I have personally seen 2 cases of this antifreeze, ethylene glycol, which is not in this list. Ethylene glycol, which is antifreeze, it is also abused by people. I have seen personally 2 cases who died, and they will also show bilateral basal ganglia abnormality. Basically, basal ganglia are quite sensitive to ischemia regions, and that is why vascular insults. You remember the venous infarct, we already did it. That can, and global hypoxic ischemic injury, things like near drowning, etc., can also cause this. Nobody is going to ask you neurodegenerative in FRCR. But otherwise, these things, particularly carbon monoxide, should be up there in your list. And similarly, some of these are luckily not for your FRCR, particularly the pediatric ones here. You should at least remember a few which we have taught. Yes, what do you think? What is happening in this DWI sequence?
So there is restriction diffusion in the globus pallidus bilaterally and symmetrically.
So the differential remains the same, and this case was a case of carbon monoxide poisoning. Over to you. This patient has got SLE. What do you think is happening?
Okay, the bilateral periventricular white matter focus of restriction diffusion in the posterior limb of the internal capsule, as well as higher up in the corona radiata. My first differential would be a vascular pathology. Infarcts in SLE, infarcts in SLE are common, I think.
Okay, very good. So why am I showing you this? And it will make this more, important for you when in the next session, which will be next time, we will cover a bit of white matter abnormalities like MS, etc. Please remember, when a patient comes to your, in your clinical practice, what happens is when a young patient comes to you with white matter abnormalities, there is a bit of differential diagnosis. We are talking about young patients here. MS, of course, is up there, and there are a few others which we will cover next time. But one of this is vasculitis. Now, your neurologist also, you remember whenever they are diagnosing a case of MS on the basis of MR, they always do a vascular screening. And vasculitis is a huge subject, slightly beyond 2B level, but you have to have a concept so that you can tackle it in the examination. What else can it be? What else can it be? And this, we will revisit this when we will be covering multiple sclerosis. So now vasculitis, there can be 40, 50 different cases of causes of vasculitis. But these connective tissue disorders, all of them can have, this vasculitis means the small vessels, they are involved. And you can see this periventricular high signal, as if there is a small vessel ischemia going on. With that, there are lacunar infarctions. By definition, lacunar infarctions, the word lacune was coined by Fleschner, who is a radiologist from USA, I think in 1960s. A lacunar infarction is an infarction which can be between 5 and 15 millimeter. And the concept is that it is supplied by an end artery, by a small vessel, and that is why we call it a small vessel. And when there is a large territory infarction, we call it a large territory, as in MCA, ACA, PCA infarction. So you can see lacunar infarctions here. Bilateral means something is happening. So in SLE, because of vasculitis, these kinds of findings can be seen. So this is the differential diagnosis of vasculitis. And many of these things are beyond your 2B, so don't worry about this. But remember this collagen vascular disease, SLE, rheumatoid, scleroderma. In your clinical practice, always remember drug abuse, vasculitis. I have seen so many of them now. And these patients, they will, at times, they will not initially, come out with this. Amphetamines, we call it hypersensitivity vasculitis. And they will come again and again, and they are actually on drugs. And these are what we call the recreational drugs. Moyamoya is also given there. Last 2 or 3 or 4 cases, I think, just for pattern recognition, then we'll stop. Yes, please.
Okay, on the...
Is there an acute infarction?
There is restriction diffusion, so...
So clinically, we were worried about infarction, so there is restricted diffusion, right?
Yes.
What else is happening? So this is your exam case, satisfaction of search.
In the left CP angle, there is a high, I think there is a high T2, low, is that a fat saturated sequence in the in the top
This
row?
one?
Yeah.
Flare.
So there's a lesion in the left CP angle, which is high on T2, and it suppresses on the flare. Is it flare of fat saturated? But it restricts on diffusion weighted image, so it could represent an epidermoid cyst.
Excellent, well done. So this was the idea these are two different findings and two different causes of restricted diffusion in one case. Satisfaction of search is what we are talking about. That's an incidental finding, and that's an epidermoid cyst. Please remember, epidermoid cyst on a flare sequence, unlike an arachnoid cyst, will show you a bit of signal like this case. But the diagnosis is made on DWI, and it shows restricted diffusion. On a CT scan, an epidermoid versus an arachnoid cyst, both will be low density, and you will not be able to pick up the difference. Yes, please. Right-sided body pain and temperature and...
Okay, so there's abnormal high signal in the left side of the medulla. And there's corresponding to restricted diffusion in the left lateral medulla. So this is in keeping with lateral medullary syndrome.
Right. Now, this case, again, please remember, I have shown you a case of cavernoma of the medulla, on a CT scan. I am showing you lateral medullary, here I am just showing you limited sequences. And please remember, in the main exam, it will be so difficult to pick up unless you see it carefully. So in lateral medullary syndrome, what happens is that on the contralateral side, the patient will have loss of pain and temperature, and on the ipsilateral side, symptoms will be sensory and motor, particularly cranial nerves and face. So this is a potential whatever question. This patient has got suspected lateral medullary syndrome. On this DWI sequence, there is something happening there. But we are not very convinced on T2, on flare, on this PD. And please remember, in this region, there are always artifacts on the DWI sequence. What can we do to resolve this issue? Over to you.
To be honest, I'm not sure. Would contrast enhanced images help at all?
Okay, so technique is what we are talking about. And these days there is a lot of literature of doing 3-plane DWI. And in this particular case, this is what we did. In many of the neuro centers now, particularly in stroke patients, they are doing 3-plane DWI. So you do a axial, you do a coronal, and you do a sagittal. And on recall, this patient, we recalled, within the next 2 hours actually. And you can see here was the doubtful finding, but now it becomes, you are more confident. And here on a sagittal, you see, look at this T2, ADC. So what I wanted to show you is 3-plane DWI. And some centers are using it as a standard thing. Last case of the day, and then we'll stop.
Okay.
Over to you.
These are non-contrast axial images of the CT head. There is diffuse loss of gray white matter differentiation throughout with the pseudo-subarachnoid sign due to diffuse cerebral edema. This is in keeping with hypoxic ischemic injury.
Excellent. So you see, this type of case has come in the exam many a times, and the YY is, there is loss of gray white matter differentiation. Pseudo subarachnoid sign is always asked in the exam. Please remember, when there is global ischemia and there is loss of gray white matter differentiation, the vessels and the dura, etc., and the leptomeningeal vessels, they appear as high density and giving you this pseudo subarachnoid sign. And here again is this Monro-Kelly hypothesis. In a dead brain, what happens? Monro-Kelly hypothesis has been asked in the exam, vis-a-vis. I showed you last time spontaneous intracranial hypotension. Also, why is there ischemia and head injury? This is another scenario. But basically, what happens is that intracranial cavity is a closed space because there is bone surrounding it. Within this space, there are three things. One is CSF, second thing is brain tissue, third thing is intracranial blood. The blood is within the vessels. Water is within the brain. We know that most of the tissue of the body is made up of water. So the hypothesis is that all of these things are in the equilibrium. And basically what happens is that if one thing increases, the other has to decrease. So whenever there is edema, there is compression of the blood vessels. And in a dead brain, what happens is that there is so much intracranial, there is so much edema, there is complete loss of sulci. And if you do an MR of this kind of case, this is another case which is now more or less brain dead. You can see that there is herniation through the foramen magnum, etc. There is so much edema inside, so much pressure that no blood is going in. This is an MRA of this case, and you can see there is no flow within the intracranial cavity. So this is imaging finding which sort of confirms brain death. Please remember that various countries have got various types of legislations, and brain death usually is not, imaging is not done, but at times imaging is asked for. And the main concept is that when there is no intracranial blood supply, or there is no, subarachnoid internal carotid artery is not supplying any blood, then you can call it brain death. You can use PET scan, SPECT, you can use MR, CTA, DSA for this. But this concept has been asked in the exam again and again. Okay, so here we stop today. If you see, I have shown you case after case after case. I told you that statistically speaking, CVS is the most commonly asked cases in the exam, and you will see that most of these cases are not difficult. They are just, develop your eyes to pick them up. So the feedback form is in front of your eyes. So please give more and more feedbacks, as I always urge you.